Good afternoon, ladies and gentlemen. I hope that you are still awake after such a long day of philosophy and brain and mind interaction. I'm going to take you into a very practical part of stroke prevention, which is a very important one because the burden of stroke is huge, as you all know, and we're talking about 16 to 17 million stroke per year around the world. We have mainly in the high incidence rate in low middle income countries. 26 million people are living or survivor of stroke with disability. Stroke is the second killer around the world, but it's probably the most cause of disability in the elderly, and not just in the elderly. So it's a huge burden. The WHO, as I happen to be the vice president of the WHO, has taken the slogan to say stroke is preventable and treatable. And the word preventable is very important. The question is how we can do it. Can we do it? And I think that yes, we can, but the question is how. We all understand that we have an advanced treatment in stroke, especially in the acute ischemic stroke with thrombolysis and recently with thrombectomy that was proven to be very efficacious in acute stroke management, ischemic stroke management, with number needed to treat, an amazing number, 2.6 number needed to treat in selected stroke patients. However, still, there's a lot of patients that are not giving the prevention of, or the treatment of acute ischemic stroke, and the question is, can we prevent? And I'm not talking about primary prevention because this is not our task as neurologists. We usually don't do the primary prevention interventions, but secondary stroke prevention is a huge burden, and we have to at least try to prevent the second stroke. So how do it? We have to find treatments that are suitable to particular group of subtype of patients with stroke. We know that stroke is not one disease. We have different etiologies, and different etiologies, we have to tailor our stroke prevention to this particular etiology. So the best way to do it is to do randomized controlled double-blind study to find whether this treatment is efficacious to this particular condition or this particular situation. And then we have, second one is randomized control study and cohort study, etc. We all know the hierarchy. So the randomized control studies are with us kind of what we call the EBM, the evidence-based medicine, based on these results of randomized control study, have their own strengths. They are prospective, they are controlled, they are blinded, and their definition of the population is very well defined, and we try to always have homogeneous type of population. We have a lot of information about the cohort, and the internal integrity of the data is very high. And many guidelines are based on these randomized controlled double-blind studies with what we call A1 kind of recommendation, the higher strengths of recommendation in practical approach to patients. So we have secondary stroke prevention guidelines, and you can see this is the American guidelines. The last one was published in 2014, and we have also the European stroke guidelines, And we have also the European cardiology guidelines. This is related to the cardioembolic stroke. We have the NICE. This is the UK guidelines. Many guidelines. You have a list of guidelines. Just to read it takes about 1 year. And management of stroke transit ischemic attacks, as well as the ESO, the European Stroke Organization guidelines, that are currently under revision. The last one was in 2008, but piece by piece, the recommendations are currently under revision. And there are many studies, starting from the aspirin trials, going to the new ones with ticagrelor and the Socrates trial that was neutral, the dual antiplatelets, whether are good or not, that's still going on, the POINT study, new oral anticoagulants for cardioembolic stroke. We all know that's all the studies that were performed. We have currently the ISUS concept, the embolic stroke of unknown origin, and recently the IRIS study about recent insulin resistance. We also have for interventions, symptomatic carotid stenosis. We have intracranial stenosis guideline, and many unanswered questions about intervention. So many guidelines, and you are all familiar with the data, are based on these randomized, double-blind, controlled studies. Very nice. You all know how much time it takes to conduct all this study. The first aspirin study was published as a secondary stroke prevention, was published when? Who knows? They are not old enough for that. It was published in 1978, and since then many other studies were conducted, expensive study, very kind of tedious and long time taking studies, a lot of billions of dollars were spent, and some good results came out of it, but as all of us know, many of the studies were actually failed. And many of the studies, in spite of well-advanced design, failed to show efficacious results. So the question is, what shall we do? What are the other strategies that we can apply in order to find maybe a more easiest way or more efficacious way to prevent recurrent stroke in 2016? I'm not saying that we should ignore double-blind, randomized control study. I am an EBM guy, the evidence-based medicine, but I understand from my experience that this will not give the answer to a real-life, all-population-based results. It's always focused a very kind of subgroup of patients, homogeneous type of patients, but will not give the answer. It's not always generalizable. And the question is, should we go to the individual high-risk approach? And this is currently the approach. You take high-risk patients and you try to find a drug or approach to prevent second stroke in this particular patients. Or this is high cost, as I said, and the population impact is not that high because it's concentrated, as I said, on a very specific type of patients. The other one, and I think that the randomized controlled trials, as I said, has their weaknesses. Generally small sample size, protocol-driven care, center and patient selection narrowly defined, as I said, difficult, not always it's easy to implement. If you take, let's say, the IRIS study, I mentioned it, IRIS study is trying to see whether pioglitazone is good to prevent stroke in patients with insulin resistance. Patients. How many of you are doing insulin resistant tests in your patients, non-diabetic patients? How many? Raise your hands. No one. You're sleeping? No one is doing it. And the results were positive, very good. However, the drug has side effects. You gain weight, there's edema, and there's a fear of bladder cancer. It's the way it was conducted, very well done. But whether this will be implemented in practice, I doubt it. I doubt it. So, and do not always reflect real-world situation, and of course, the all high cost. All of them, all the EBM, as I said, has internal validity. They're very good, and the results apply to this particular group of patients that you tested. However, the question is whether it has external validity. Means in real world, whether this result will repeat themselves and be good to the rest of the world, not just those that were included with the inclusion and exclusion criteria. So randomized controlled therapeutic trials or double-blind studies has their limitations, as we see. And I think that the analysis of real-world data means registries, and I believe in well-conducted registries can give you a lot of information if it's done correctly, if the design of the registry is controlled, and you know what you're doing. And I think that the real world is actually can complement. I'm not saying that this is the only way, but should be implemented as part of our strategy in order to find secondary stroke prevention, which will apply to the whole world, not just to this particular sample of randomized control studies. And you'll see a lot of information coming from the real world, and even the American Heart Association back in 2011 recommend to use and to have a policy to apply registries in trying to get appropriate secondary stroke prevention or secondary prevention also in myocardial infarction. So in order to achieve a global stroke prevention, we need to shift strategy. Instead of going for the high subgroup risk of patients, we need to go to a mass prevention strategy. I think that evidence-based approach to promoting health behavior, not just particular drug, not just one part of approach, but a general lifestyle and behavior changes, innovation, multidisciplinary research team, science, not just one team, but trying to get all stakeholders to get together and to find strategies, mass prevention strategies, and advocate for improved health. So I think that stroke prevention, as I said, population impact on this high individual risk, the impact is less. We need to find a population mass approach where the impact on the population is high and the cost is much lower, much lower. And therefore, the international strategy and collaboration, it was held in 2011 in the UN, and this was the NCD, the Non-Communicable Disease Political Declaration. I was privileged to be there together with Bo Norving. At that time, he was the president of the WSO. I am the vice president, and we attended this historical, I think, UN Assembly, General Assembly, where they declared to fight non-communicable disease, including diabetes, heart, and stroke, cancer, and pulmonary diseases. And this was signed by 130 states representative, and now the WHO is actually trying to implement and reinforce the government to take measures in their own countries, population-based measures, like reducing salt in the industry, products, and smoking campaigns, anti-smoking campaigns, etc. And the idea was to decrease the mortality of NCDs 25% by 2025. And this is the aim, as well as to reduce about 30% reduction in stroke and in 2030. The WSO, the World Stroke Organization, also put the prevention on his flag as part of the strategy, and they've established also a strategy for prevention of stroke, not just the acute stroke treatment, which is very heroic, very important to save life and to reduce disability in acute stroke, but we should prevent stroke. This is, in my opinion, a better strategy. One of the things that emerged from the interstroke case control study, 32 countries that were involved in this, and these are the data that was published, of 13,000 cases, or 13,500 cases, they found actually that all these modifiable risk factors, 9 of them, if they are all will be well controlled, like hypertension, diabetes, lipids, if you do some exercise, you move, you have to sit in the chair over here, but run around Athens, especially the mountains, and you prevent cardiac disease like atrial fibrillation, you can reduce the risk of stroke by 90%, 9-0. This is absolutely incredible. Can we do it? I think that campaigns, the massive population campaign should be done in order to increase the awareness of these risk factors. We know, unfortunately, that in spite of the fact that all risk factors are known, if you look at stroke etiology, about 1/4 of our strokes are of unknown cause. So what is unknown? Professor Korchin is talking about the unknown of the unknown. So what is the unknown? We still don't know all the risk factors. There should be what we call emerging risk factor. There's another topic that I can give you a lecture, half-an-hour lecture on this, the new emerging risk factors. For instance, just recently, we know that atrial fibrillation, with a very known cause of cardioembolic stroke, doesn't tell you the whole story of the heart. There's a new entity called the atrial cardiopathy, which means that the left atrium has another pathology that can be detected without the atrial fibrillation, because many of the strokes occur, even in paroxysmal atrial fibrillation patients, occur not during fibrillation. So what is the cause? Is atrial fibrillation just a marker of other pathology within the heart, within the atrium? I think that Professor Korchin is very happy about it, because he always triggered me about this. And I believe that currently I'm convinced that we should look for other risk factors. Of course, genetics is an emerging risk factors, and there's a group of people that's consortium of vascular genetics that trying to find out the genetic mutations and factors that contribute to the risk of stroke. As I said, as it was said in the morning also, that genetics is not the whole story, because there is some, what I'm trying to say that there is risk factors which tells you why me. But it was mentioned also, I think that Professor Krochin also mentioned it, why now? Hypertension is there for many years. Carotid stenosis, asymptomatic carotid stenosis is there for many years. Why now? In this particular point of time, boom, there is a stroke. It could be there are many infection, stress, all kind of other trigger, that's what are called stroke triggers that we should identify, not just stroke risk factors, but also stroke triggers that will tell you why now. Of course, we have to find this, we have to fight the stroke risk factor as well. We have also we have to look into the vascular wall. In my opinion, the vascular wall, the arterial wall, is a very important issue. And nowadays, we have an advanced technology to identify and to image the vascular wall. High-resolution MRI will give you a lot of information about the vessel wall that is potentially a risk of clotting and stroke. So I think that we should still have to explore intensively the unknown risk of stroke or triggers of stroke that should give us opportunity to prevent stroke. So combination of risk factors, soluble marker, plaque imaging, genes, vessel wall, and other, we should open our mind to explore other potential risk factors. So I think that stroke prevention in 2016 or 2017 is interventional approach should be mass approach. We have to go into pharmacotherapies and to explore more of them, new drugs, lifestyle and behavior modification. I cannot stress more. It's difficult here in Athens to do that, but at least we can try. So don't eat too much, don't drink too much and run around, and of course all the other. And I think that we should also urge the healthcare systems and the providers to pay more attention and campaigns to stroke prevention of all the modifiable risk factors. I think that's not much and not enough is done. And I think with the NCD, WHO, that's currently there will be a new General Assembly of the UN in this coming September to try to see how much is achieved from the time in September 2011 when this declaration was launched. So I think the challenges in stroke prevention, the current and future burden of stroke is great, increasing as our population is aging. Adherence to evidence-based recommendation can help, but it's always followed and always not easy to implement. Lifestyle modification are important for stroke prevention, but not easy to achieve. How many of you are doing exercise on a permanent basis? Raise your hand. You are not lazy people, huh? But there are some people that are reluctant to raise the hand because it's too difficult to raise the hand. Exercise. Raising the hand. Crazy. So I think that keep your weight under control. And I think the American Heart Association goal in 2020 goals and the UN NCD target will require collaborative approaches to shift the population ideal cardiovascular and brain health. And I think that's what we do, is mass prevention and innovation of multiple disciplinary research and advocate to improve health. So I think that's, can we do it? Yes, we can. We need a collaboration of all the disciplines, all of us together, to change our strategy, and then we live healthy life almost forever. Thank you very much.